Thank you for the organisers for inviting me to speak today. It's a real pleasure to be able to talk about gluten challenge in celiac disease. So hopefully my screen is starting to share now. These are my disclosures. So gluten challenge in celiac disease is a very long history, and traditionally it was used as a way to confirm the diagnosis of celiac disease in children who had histologic damage and then had gone gluten-free. But with the advent of better serology, this is no longer needed. And I think in the clinic, we most commonly see gluten challenge used nowadays for people who have commenced a gluten-free diet prior to formal testing for their celiac disease. But what I really wanted to focus on today was the role of gluten challenge in understanding celiac disease biology and advancing our understanding of new drugs and their development. So we know that gluten challenge has greatly informed on the knowledge around the specificity of T cells to gluten, but also has helped us design new potential therapeutics, test that they're actually working, and take these through to clinical trials and look and utilize it as an efficacy endpoint. So what I really want to talk about now are three key things: the effect of gluten on symptoms, the small intestine, and the immune system. So we'll start off with symptoms. And I guess the first point to make is that symptoms in celiac disease can be chronic in people with untreated disease who continue to be exposed to gluten. There's a specific set of symptoms that we know and talk about. But what I'm going to really focus on are the people with treated celiac disease who are then given a gluten challenge, an acute amount of gluten. And from studies looking at either single doses or over 3 days or anything from 2 to 12 weeks, we know that there's a distinct behavior to these and the nature of these symptoms that's quite different to chronic symptomatology. We know that symptoms typically occur on the first day of the gluten challenge, and we've shown that this often peaks around 3 hours after the gluten is consumed. But there is considerable heterogeneity between patients, both in the types of symptoms they may experience and the severity. And there's also variation within the same individual at different time points. Even when they're exposed to the same amount of gluten at different time points, they can have slightly different responses. There is a dose-response effect. Larger amounts of gluten are more likely to trigger stronger responses, but we know that even low doses for some people can trigger a symptomatic response. And anecdotally, we've certainly noticed that whilst the first day triggers the worst symptoms, if people continue to consume the same amount of gluten, and this is obviously as part of research, interestingly, most will report a reduction in symptoms by day 2 and day 3. So if they vomited on the first day, that's very uncommon to happen on the second or third day. So we often encourage our people to keep going through gluten challenges in our research studies and have observed this phenomenon. But why it occurs, we don't really know. And you can see on the slide there a graph of some of the symptoms that are reported by people after wheat challenge, barley challenge, rye challenge, or oats challenge. And this is a rather old slide. Those numbers are considerably larger now, but I think the picture there highlights that there is a difference in the types of symptoms between grains. For example, after wheat, it's much more common to have vomiting, and after rye and barley, this is less so, and oats were generally very well tolerated. So interestingly, there have been very few double-blind, placebo-controlled or sham-controlled gluten challenges that have taken place. Dr. Anderson, who's in a session following mine, will be talking a little bit more about this, but this data has been really interesting because it tells us when you couple a gluten challenge with an immune readout, you can learn a lot about the nature of symptoms. And nausea and vomiting appear to be the two sentinel symptoms that occur with gluten challenge that is closely linked with immune activation, whilst there is a lot of other symptoms that occur. And we do know that irritable bowel syndrome is common in celiac disease, and there are other dietary triggers for irritable bowel. So you may have heard of these fermentable carbohydrates termed FODMAPs, and wheat contains a FODMAP called fructan. Dr. Lunden, who you heard of, speak earlier today, has done good studies using fructan in non-celiac gluten sensitivity and shown it's an important trigger of symptoms. So when people have symptoms after gluten, sometimes it's due to gluten, but sometimes it's due to other triggers, including things like wheat-containing FODMAPs that are the non-gluten containing components. So it's important that we control for FODMAPs in the gluten challenge to ensure that we are only getting gluten-specific effects. Okay, so what about the effect of gluten on the small intestine? So this slide is really just an example of recent studies that highlight the heterogeneity of study design and also outcomes. So you can see the top 4 studies are really looking at 2-week gluten challenges, and then studies 5 to 7 undertake 6-week gluten challenges. You can see that the format of the challenge is different in the way the gluten was given. The doses are variable. Obviously, the number of sample sizes is different. And the baseline level of damage is variable as well. Point is, those cells highlighted in red, there is a significant deterioration in mucosal villus height crypt depth and a significant increase in intraepithelial lymphocyte count, so inflammation. But we can appreciate there that there's when there's data in the cells, it's because the paper had that data, that there is differences in the proportion of people who develop that degree of enteropathy. So why do we have this variability? So clearly, the dose and the duration of gluten is a key factor here. Longer a duration, higher amounts will provide more consistent results over the population. How we measure gluten is an area of discussion. I don't think there's any standardized approach to that. And how we deliver the gluten, whether it's given as a drink in a slurry or baked into food, probably has food matrix effects that will also affect outcomes. At the other side of the equation, how we assess small bowel histology is a really crucial factor in determining how enteropathy is measured, where we sample the duodenum, whether we undertake a quantitative morphometric approach to reporting histology, who the histopathologist is, whether they reject inappropriately, sorry, mental blank there, whether it's a longitudinal or slightly obliquely sliced sample, those things all will impact the quality of the histologic readout. And then finally, patient factors are going to be important. So we know that baseline damage will affect a lot of the response to gluten. And Dr. Lunden and his team, for example, have shown in a 2-week gluten challenge, when you look at those people who had histologic damage, that was more common in those people who had evidence of baseline damage and larger amounts of gluten-specific T cells in the small bowel, so suggesting that they were primed and ready to activate. Other factors like HLA are likely to be important. And also, interestingly, previous studies have shown an observer or a Hawthorne effect. And this is when people in a clinical trial for celiac disease, even without any intervention, can improve their histology just through the simple act of being in a clinical trial and presumably altering their behavior and potentially being more strict with their gluten-free diet. So you can see that there are a number of factors that can impact the histological response to gluten. Okay, so let's have a look now at the immune readouts to gluten. We commonly use celiac serology as a readout. This is used both in the clinic, but in clinical studies as a marker of disease activation. We know that there is a dose-response effect, but we also know that the response to gluten is quite variable. You can see an example on the slide there. But what I really wanted to talk about are some of the evolving methods to assess one of the key pathogenic cells in celiac disease, the gluten-specific CD4 T cell. And what I'm going to talk about now are some of the blood-based methods to assess this very important pathogenic cell. And I think that these methods are now allowing us to much more simply assess this cell to the level that I think will be much more commonly employed, these approaches in the clinic and also in research and clinical trial applications. So Dr. Bob Anderson, who is talking later today, developed a method back in 2000 where he showed that a 3-day wheat gluten challenge induced gluten-specific T cells in the blood of people with celiac disease. It didn't occur in people without celiac disease. But on day 6, you can collect the blood and isolate gluten-specific T cells that were gut-homing, HLA restricted, pro-inflammatory, and secreting cytokines that were typical of the chronic celiac lesion. CD8 T cells also appear to come up, but the focus has been mostly on the CD4 T cells. Using this 3-day challenge tool has provided great insights into the nature of the gluten-specific T cell response, the types of gluten peptides that trigger T cells. It has allowed us to screen for celiac-safe cultivars of different grains, and also be used in preclinical and clinical trial development as a way to identify novel drugs and assess their efficacy in trials. But more recently, as you'll hear a little bit later, this is starting to pivot towards a single gluten challenge. And this was from an immunotherapy trial that showed after injection of gluten peptides, there was a striking blood-based cytokine signature dominated by interleukin-2 occurring within hours of that gluten injection. And then I went on to show with oral gluten challenge, this similar signature was present in the bloodstream, and about 2 to 4 hours, peaking around 4 hours after gluten is ingested, people with celiac disease, but not those without celiac disease, will have this striking elevation of interleukin-2. And this correlates with the magnitude and severity of the symptoms that person may experience to gluten. And so this seems to be a very early and sensitive marker of the gluten-specific T cell. So in work we've done with our Norwegian colleagues, it looks like that the gluten-specific T cell is the main source of this interleukin-2. So this is shaping up to be a really nice readout of the gluten-specific T cell response, but also as a marker of symptom severity or symptom readout, and where it's being used now as a endpoint in clinical trials and to assess eligibility. And this very nice study by Drs. Leonard and Sylvester undertook a 2-week gluten challenge in 2 sites and then looked at traditional markers and readouts, which generally take a longer time to become meaningful, and usually with a higher dose of gluten. So you can see here 10 grams, there were some meaningful readouts, but at 3 grams, much less so. But here at 4 hours, the interleukin-2 signature in the bloodstream in those people with celiac disease was highly informative of that gluten-specific T cell response. So this is now gaining some interest in drug development, in measuring the gluten-specific T cells in clinical trials. But what I'd like to talk about now is how we've employed this technique to address a fairly important or a very important dilemma in the celiac space, and that's around oats. So oats safety is generally considered to be fairly well established. However, we do always hear from some patients, and this is after talking to representatives from patient associations across the globe, that there's a subset of people with celiac disease who describe adverse symptoms and reactions to eating oats. And this includes contamination, wheat contamination-free oats. And traditionally, many of us would have thought, oh, well, maybe it's just the fiber, maybe it's something else that's making them sick. But we do know that oats contain sequences that trigger intestinal T cells, avenine-specific T cells. So avenin's the prolammin protein in oats. And we've also shown that when people with celiac disease consume oats for 3 days, T cells recognizing avenine are apparent in the bloodstream. And interestingly, the sequences that these T cells recognize share very close homology to barley ornine sequences that are known to be immunogenic. So this kind of molecular mimicry that occurs suggests that it is these sequences in oats that are recognized by T cells that can include barley-specific T cells that could potentially drive damage in people with celiac disease. So how do we resolve this dilemma between safety in feeding studies and immune responses with T cells on the other hand? So we took some inspiration from history, and I love this paper on the left that I found from 1958, The Archives of Disease in Childhood, which was exactly looking to try to establish safety of oats in children with celiac disease but they ran into problems that the children were struggling to eat enough oats to really establish a good signal. And they commented here in their discussion that the use of oats protein was considered, but they had difficulties in isolating that. But in the future, if you could isolate that, that'll make a great vehicle to use in challenge studies. Finally, in 2019, working with some cereal chemists, my group was able to isolate food-grade avenin from oats. So we had over almost 1,000 pounds of oats and isolated a small amount of oats that you can see there in that little picture. So probably the most expensive white powder that I'm ever going to get into contact with. And this was the basis for our feeding trials, which you can see some data here. And what we did here was feed people with celiac disease small amounts of this oat avenin protein and then measure interleukin-2 at the 4-hour mark. And you can see here the 0.5 gram dose is approximately that equivalent to a 50-gram bowl of oats, so a decent sized bowl of oats. So we went all the way up to the equivalent of 12 bowls of oats, or we went down to about a tenth of a bowl of oats. And you can see here that there's about 38% of those people with celiac disease that had an immune response, and some people had striking elevations of their IL-2 compared to baseline, and that this increase was mirrored by symptoms that they experienced, which were mostly gastrointestinal. And here we have people vomiting, looking pale, looking horrible, feeling really unwell after having purified oat avenin, which was quite striking because this was not something that was really appreciated before in terms of the severity of these kinds of responses, but we were able to do that because we could push the dose high enough. And we showed that with this acute activation, as expected, avenin-specific tetramer-positive T cells could be detected and increased. And an activation marker discovered by and reported by Dr. Linden and his team, CD38, was also activated consistent with the challenge that we'd undertaken. But here's the really interesting thing. When we got those people who had initial responses with interleukin-2 to oat avenin and then said, please, can you keep eating that for 6 weeks daily, even though you got sick, those symptoms disappeared fairly quickly within a couple of days, but also by the end of the 6 weeks, there was no evidence of histologic damage in people, no villus atrophy, no inflammatory change overall, and no increase in celiac serology. The red line here is a control patient who consumed wheat for 6 weeks, not oats, just as a way that we can confirm our readouts were all working, which they were. So clearly, oat avenin was activating responses and symptoms in people. And we know these weren't nocebo effects. These were real symptoms because the symptoms were accompanied by very real increases in a biomarker in the bloodstream. But protracted ingestion, reassuringly, was not associated with histologic damage, at least at the 6-week mark. Whether longer-term exposure may be harmful was not explored. But it does suggest that there is a true subset of people with celiac disease who may be affected by oats. Now, this really does support the idea that oats should remain a priority allergen as dictated by Codex. But you know, we still encourage oats for the broader celiac population who can tolerate it because of its very positive beneficial effects. So this is not a cause for alarm in those people tolerating oats. They should have their usual medical follow-up. But for those people who do have adverse symptoms and struggle, this might be something that could be looked into a little bit further, and potentially they should be avoiding oats. But it raises another interesting question, and I know that raising questions is an important focus of these sessions, and that is this idea of molecular mimicry, which we've shown in bacteria with gluten, Pseudomonas, but also we're looking at now other gluten-free grains that contain sequences that may mimic gluten. Could these potentially drive gluten-specific T cells in a subset of people with celiac disease? So no cause for alarm that there's any gluten-free grains doing this, but this is the basis of another project that we're doing to really understand if some people may be susceptible to effects from traditionally considered gluten-free grains. So I wanted to briefly touch on I'm just getting some messages here. I'm making sure that I'm not going over time. Oh, 2 minutes remaining. Okay, how does gluten cause symptoms? I'm going to just go very quickly now and mention that, look, we know there's an acute immune response to gluten dominated by interleukin-2, but we've shown that there's a broader range of cytokines and chemokines produced to gluten. But how does this link in with the subsequent symptoms that people may experience? Serotonin is a really potentially important mediator. We know that it's important in irritable bowel, and symptoms in irritable bowel similar to celiac disease. We know that ondansetron in patients vomiting in celiac disease can be helpful after a gluten challenge, anecdotally. We know that infusion of serotonin in healthy volunteers produces symptoms just like a gluten challenge. And there's some biological evidence for the role of serotonin in symptoms. For example, in an open label trial, thank you for that message that I can keep going for another minute or so. Thank you. With the gluten challenge, open label gluten challenge, by this study on the right-hand side of the screen here, you can see that there was an increase in the people with untreated celiac disease following a gluten meal, quite a large gluten meal, increase in the circulating serotonin compared to a very minimal increase in healthy controls. And that this rise in serotonin correlated with the severity of gastrointestinal or dyspeptic symptoms. And they also noted an increase in mucosal production of serotonin in that study. So this doesn't necessarily this doesn't provide the answer yet, but what we're really looking for now is evidence of how do we link this acute immune activation with interleukin-2, gluten-specific T cells, these other cytokines, with perhaps downstream mediators of symptoms like serotonin. And we postulate that the enteric nervous system must be involved in that process. Endocrine cells, or the endochromaffin cells that store preformed granules of serotonin, could be somehow triggered by these immune signals and triggered to release their contents of serotonin or other mediators. And it's possible that those patients who are asymptomatic, who don't get symptoms to gluten, somehow this pathway is disrupted. So studies are underway to explore this at a more cellular level, and we look forward to seeing what that tells us about the nature of symptoms. So finally, we are evolving beyond just many days of gluten challenge to single challenge, and now we're looking at ways to do the gluten challenge in a test tube to avoid participants with celiac disease having to gluten challenge at all. And we know that there are very sensitive ways to detect these gluten-specific T cells in the bloodstream. For example, using tetramers, very sophisticated, technically demanding approach using these molecules that can actually identify specific T cell receptors. So very, very sensitive, but do require large amounts of blood, often 50 mils or more, and proprietary agents. And you do need to know that person's HLA type to then pull out the most HLA-restricted relevant peptides. More recently, we've been working on, and this is with Dr. Anderson, a whole blood-based approach. And this is then taking whole blood, incubating with gluten peptides, and measuring interleukin-2 the next day. So essentially, we're doing a gluten challenge in a test tube and then showing a gluten-specific T cell signature. And again, we've been able to show that this is very specific for celiac disease. It may facilitate epitope mapping and also immunomonitoring. And so here's some preliminary data that our group is doing in people with celiac disease, confirmed celiac disease on the left, and those with confirmed not to have celiac disease on the right. This is preliminary data. We're still identifying optimal cutoffs, but based on a cutoff that we've identified to date, and this is 51 people with treated celiac disease, so they're on a gluten-free diet. 100% of them had negative celiac serology. 90% were detectable by this assay. And if you include the two that were on steroids for Crohn's disease, if you exclude those two, it will be 94% sensitivity. And the 35 people without celiac disease, if you take both of these cutoffs, 100% specificity. So promising early data to suggest that this whole blood assay may detect celiac disease very simply. And so closing slide now, I think gluten challenge is really clearly an important part of the field. We do need to standardize protocols and adjust them to the indication that they're being used for. Mechanistic data on the nature of symptoms is important. We really need to develop PROs, patient-reported outcome measures, that are developed specifically for gluten challenge, because some of the symptoms like vomiting are not recorded on traditional patient-reported outcome measures. We need to work out how to encourage participants with celiac disease to take part in gluten challenge trials, because it's not pleasant for them, and we don't really want to do it if we can. So I think this means that we also need to pivot towards methods that minimize gluten challenge in the patient. And I think that this will increase, these techniques and approaches will hopefully gain more traction in the future. And I think that we are really seeing an evolution from a histological-based diagnosis of celiac disease now to the Espegan criteria, where we're accepting that serology may be sufficient in a subset of people with celiac disease to diagnose it. And so perhaps provocatively, maybe in the future, we pivot towards a truly immune definition for celiac disease, where we say the gluten-specific T cell is what defines the presence of celiac disease, which I think will broaden the kind of types of people that may be encompassed within the definition, who may have minimal enteropathy, for example. But I think this may be potentially, if validated in the future, a way to reimagine how celiac disease is defined. So I'm going to finish there. I apologize for going over time. Thank you to my team, and thank you for listening.
Thank you. Thank you very much, Dr. Tyden. Lots of questions, provocative discussions. I think we'll have our roundtable back on again. So thank you. And Dr. Stahl, just to remind everyone, she's the research director, a pediatric gastroenterologist at the Colorado Center for Celiac Disease. And Dr. London, who's been also with us throughout the day, along with Dr. Stahl, who's a professor at the University of Oslo. Dr. Jabri, my co-moderator, I'm going to hand it to her.
Okay, so thanks. Maybe because I know this roundtable is around symptoms, but I just would like to ask one question, and then we'll go to the roundtable to Jason. In your oats patients, we know that in order to have villus atrophy, that the gluten-specific CD4 T cells are required, but not sufficient. Example, potential celiac patients, mouse models, etc. Do you know if in your oats study, you are lacking either IL-21 responses in the CD4 T cells or lacking epithelial stress responses?
That's a great question, Bana. We don't have that data yet, and that's why you and I have had these discussions about exploring those aspects. I think that will be very important to understand. And, you know, I think we were also trying to look at CD8 T cells and other cellular players that could be relevant here, and to try to understand the difference, whether it's a quantitative or qualitative difference at that end, time frame after the 6 weeks. It's unclear. I mean, what we showed with the wheat challenge patient was, interestingly, the tetramer positive cells did decrease over time, and the activation of interleukin-2 at the end of the 6 weeks was also minimized as well. So there must be other, I think, qualitative differences to the adenine-specific T cell or other cellular co-players in this.
Okay, thank you. Now let's go to the roundtable. I think there's a lot of interest, and I think that, you know, the study that was done in the context of the vaccine trial of Immusanti is a fantastic example of how, when you associate clinical trials with mechanistic studies, you actually stumble onto major observation that then can have clinical impact beyond therapeutic strategies. And I think what it put on the table was the fact that acute symptoms, as you stated, Jason, are very different from chronic symptoms. And so a question I had for you is, it seems when we think, and I want just a general description from each of you about how you think about that. There's the acute symptoms in the context of gluten contamination in patients who get gluten contamination when they go to restaurants or in other aspects or during gluten challenge. There are the chronic symptoms in the context of active celiac disease with ongoing gluten ingestion. And then you have the symptoms that persist in a subset of patients on a gluten-free diet. So I would like all of you to maybe tell us what you think about those three categories and how you would link them to mechanism. Because one thing I think that you stated very nicely, Jason, and Knut did it as well in his presentation, is that the cytokine release is acute and not chronic. And so knowing all that and thinking about now all those aspects, you know, how would you think about those three categories of symptoms, and what do you think the mechanisms are, and how do you think how should we deal with that in the context of clinical trials and future studies? So maybe we will start with the lady here, Marissa.
Thank you so much. What a great question. And I'm very interested to hear the answers that follow as well. I think, you know, the work that Jason presented is so important because it's finally kind of offering mechanisms for these different situations that you're talking about. But I think at least clinically, there is so much variability that it's really hard to tie that to some of the data. And what I mean by that is when I'm thinking about acute symptoms, there are definitely the kids who have a little bit of cross contact and are vomiting for, you know, a day or two after that. And it is very nice that we can offer them Zofran, and maybe that is related to serotonin, and maybe that is related to a more prominent cytokine release. But then there are also children that we see who have no symptoms with exposure whatsoever. And I don't, at least right now within our pediatric population, we don't have the data to say that that's because of IL-2 or not because of IL-2. There are currently studies underway looking at gluten challenge in children, but you know, I think we don't really know. As far as chronic symptoms for a patient who is on a gluten-free diet, was that your second one? Sorry.
Yeah, I just wanted us to think globally about symptoms and to not think, you know, in one aspect. And given everything we're hearing, it seems that it's not the same symptoms in those three categories, and that also the mechanisms could be different. So having your pediatric perspective is very interesting.
Yeah. And so, sorry, going back to acute symptoms, I have one other point that I want to talk about, particularly with respect to children, because there are, as I said, definitely the kids that get acute GI symptoms with exposures. But then you hear a lot of parents talking about kind of like the extra intestinal symptoms that you can get. And I think one thing I very commonly hear about is irritability with gluten exposures. And I don't know of good data that we have that really explains the mechanism of that. And then you're absolutely right. As far as chronic symptoms go, you know, I think when we're talking to patients about ongoing chronic symptoms, oftentimes it's less of like, you know, that they may have a little bit of nausea or dyspepsia, but it's usually not, you know, ongoing frank vomiting. It's more things like chronic abdominal pain, headaches, and those can be a little bit more difficult to tease out. Like, is this because of ongoing small gluten exposures, or is this unrelated to gluten because you're very adherent to a gluten-free diet? And maybe it's one of those patients that, you know, Jason was talking about who is more sensitive to oats. And I have not personally had one of those patients, but I know of others in my center who have. And so I think there's a huge spectrum of symptoms. And I don't know that we really have a good understanding quite yet of the mechanism of all of that spectrum.
Knut, your thoughts, and then maybe if you could look at the Q&A if there's any answer related to the questions that are asked.
Yeah, because these are great topics, and I think the topics that we're discussing now is extremely important for drug trials for celiac disease, which is where there is a lot of criticism about the FDA requirements, because most people would consider that the symptom relief in drug trials is not directly related to celiac disease. At least they don't fit with the acute celiac disease symptoms that Jason is showing, and we see exactly the same. I mean, this is so nice. A further small comment from me. I think it's good for the celiac community that you have done the oats challenge studies, not the least because many celiacs are confused when they react to oats, and now you can tell them this can be explained. Their reaction to oats, which is for most of them, they don't understand it, and which is not a good idea for a patient group not to understand what is going on. So I think these are important studies. Still, the interpretation of the long-term exposure to oats, there is no signal that this is of a worry, so I think this is fine. When it comes to persistent symptoms after a gluten-free diet, I think the problem there is that there could be at least two different factors leading to persistent symptoms. One is lack of compliance, of course. So you just forward the symptoms from an untreated celiac, or intermittent lack of compliance. I mean, that would be repeated acute small challenges, which is also of some concern. And lastly, we have done some work on this and looking into what we consider really well-treated celiac patients on a gluten-free diet, and we take away the FODMAP, or those who are really bothered like an IBS patient is, and you can take away their FODMAP from the diet and they improve, which again tells you that there are several factors adding into more or less overlapping or different kind of symptoms, and of course it's then we're left with a complex picture. But I would say that persistent symptoms,
Yeah, can I just jump in on this point you were just making? I think that is very important. I believe, we think about immune-related symptoms and diagnosis, but I think what we're letting out is epithelial cell-related symptoms. And there could be a whole functional phenotype linked to epithelial alterations that you could not see just on histology. That could be even an overlap between some IBS patients and celiac patients. We know that even on a gluten-free diet, the epithelial cells don't recover a completely normal aspect. So I think, again, moving forward, we may want to separate what is immune-related, what is epithelial cell-mediated, and then going back to what Marissa was saying, I think she was alluding to brain fog and so on. There could be also microbial or metabolite or serotonin or other induced molecules acutely that could be responsible for another set of responses. So maybe that's one way we could be thinking about.
But I guess the big question is, you have all these symptoms. How do you know what it's coming from unless you have assays that are developed to say this is epithelial, this is from some other thing? And otherwise, from a patient perspective, I have a bellyache, I'm nauseous. Could be the bad food I ate last night, or it could be the gluten or something. So where, I guess this is where, Jason, you have very elegantly described all those studies. And then Dr. London also showed So when is this going to happen? When will we know? When can we do that? I mean, as a patient, I want to know. I want to know. Okay, I have this is acute, this is chronic, this is gluten, this is not. And there's a question in the chat about oats in terms of if you have oats and you have symptoms, when do you take it out? What do you do? So tell us, Jason, when?
This is such a great discussion. I also agree that I think with chronic gluten exposure, we're starting to get epithelial damage and enteropathy. And I think that the way I conceptualize is a bit like post-infectious irritable bowel, that when you start to have this epithelial damage, you're probably more likely to have an irritable bowel type phenotype. So I think that a lot of the chronic symptomatology we see in celiac disease may actually be more consistent with an irritable bowel type mechanism as opposed to what we're seeing with acute gluten challenge. But we're actually quite keen to assess interleukin-2, not just in acute treated patients with acute gluten exposure, but also in people with active disease. So this is an ongoing part of our program, and we're collaborating with several different groups. This is showing, the early work is showing that we can detect interleukin-2 signals even in people with active disease after a gluten challenge. So there's still possibilities of this induction of a response in people with active gluten exposure if that amount is increased. But we need to really map that to chronic symptoms and understand that. But I think another way that some people may propose would be assessment of gluten immunogenic peptides in stool or urine. So as another tool to assess gluten exposure, to try to correlate symptoms that are reported by people and true gluten exposure. I think that's what you mentioned, Dr. Verma, in terms of how do you know if it's gluten or not. I think that we do need to resort to biomarkers, whether blood-based or stool or urine-based, to sort of get to that answer. Back to the oats question. In Australia here, we've got this situation where oats are not allowed in the gluten-free diet at the moment. So really, we do the opposite. We introduce oats into those people who have good healing at baseline, give it for 3 months, and then repeat an endoscopy. And if the patient tolerated it symptomatically and they have no damage, then we allow them to have oats. I think that's unwieldy and cumbersome. I much prefer what's happening in Europe and UK and the US. But I think the question of when do you take the oats out in someone not improving isn't fully answered. And I've had some discussions with Knut about this, I think. So Knut, you may wish to answer from your perspective about when you might want to take out oats.
The question comes up every now and then. In most recent years, not so often, but in the past, I've seen several patients with either continuous symptoms, but mostly if they have continuous villus atrophy or combined with symptoms. And taking away oats, yes, we've had success in a couple of times, but now we rarely see these questions for some reason. I don't know why. But in my view, I mean, that's what we have been doing for several years. We have in Europe, we have taken away oats if that is a problem. We have told our patients to go away from wheat starch-based diet, although the wheat starch really gives very little gluten, but still, that's what we have trying to do. And does it help? Does it not help? Well, I don't think there are any good studies here, but it is a question.
If we can go to some of the questions.
But then again, let me just say that if you have a patient with symptoms and they said, well, I eat oats, for me, it is not a big problem to advise that patient to go away from oats. Because yes, there are positive effects of oats in the general population, but on an individual basis, you don't find any effects. And if they don't tolerate oats, whether it's a belief or whether it's biology, in any case, I think it's perfectly okay to avoid oats.
I have a provocative question now. So there are a lot of clinical trials that aim at, preventing development of villus atrophy, preventing the acute T cell response. And what all of you have shown here is that a acute contamination or an acute challenge can cause acute symptoms, including brain fog and cognitive alterations, can induce fatigue, irritability that really affects the quality of life of the patients, but it is not associated with tissue destruction. So, and very likely the symptoms, even if they correlate with IL-2, may be linked not to IL-2 directly, but could be linked to all the secondary messengers that Jason was alluding to. Should we be thinking, just to improve the quality of life of patients, about clinical trials that aim just at controlling the symptoms linked to acute contamination, and wouldn't that improve, significantly the quality of life of patients? And that would be very different trials than going back to what you were saying, Knut. The FDA, it wouldn't include the symptoms that are there. It would have to be this other set of symptoms and other readouts. So your thoughts, Jason, and then Knut and Marissa. We'll go in reverse.
I think that's a great question. And I would agree. I think that one of the biggest drivers for impaired quality of life is this fear of symptoms with occasional gluten exposure. And so if we have mechanisms to block that, I think that would be very favorable. However, there's always the specter of, is there undetected enteropathy in the background that may lead to complications down the track that we have to deal with. And I think that's always been a traditional worry that we've had when we can't talk about therapeutics that solely focus on symptoms. But to some extent, as you say, if that's something that is independent of the symptoms and you can still control the symptoms, then I think that it's something that should be looked into and definitely worthwhile.
Yeah. Well, what was the question again, Banna? Let me think a little bit
about a very different way of thinking about how to target the patient.
Of course, you can. If we talk about drug trial development, of course there is a room for something that takes away the acute symptoms. That is the situation when celiac is exposed to something, or not, or if the patient knows that the only food he can take contains gluten. Okay, then give me something that avoids my symptoms. That would be fine. That would typically be a gluten degrading enzyme, and I think there is a role for that. In the same manner that you use a lactase, a pill with lactase, if you are lactose intolerant, so that would be exposure dependent on therapy. And I think there is a need for that. There are no drugs, no enzymes which fulfill that at the moment, but that may come. The other aspect is about, several trials now address healing of non-responsive or poorly responsive celiac disease. And the idea with the trials is that they direct the trials on patients that are poorly compliant. The problem, of course, with the trials is that how do you get hold of those patients? They are there for sure, but do they come to the healthcare system? Do they volunteer for trials? I see a little bit of a problem with that, because those who do not care, those who still have a lot of symptoms. I really believe that there are many patients who are not followed up properly. They are not taken care of. They don't care about themselves. They eat gluten every now and then. They have a maybe not miserable life, but they have lower quality of life than you would like them to have. And but how to find those patients for a clinical trial, that's a little bit of a challenge.
Marissa?
Yeah, so Bana, I think there's definitely a role for that in clinical trials and a need for that in the pediatric population. I mean, I know at least clinically, some of us for patients that have very severe symptoms with gluten exposures have used budesonide. So something like there is for sure something more targeted that could be used in that scenario, and we would benefit from clinical trials in that area. I think the hard thing, just thinking about doing a clinical trial like that within the pediatric population, would be what are we measuring to prove that it's working? And so there aren't really, great measures of the cognitive effects of potential exposures in the pediatric population, things like headaches and brain fog, which a lot of our patients do talk about. And then, IL-2 is a great marker, but is that really going to capture all of the symptoms that we see with gluten exposure? And then thinking about the pediatric population, if you were going to do, a controlled challenge, is that going to get past an IRB to put a child on placebo and gluten challenge them? I think we would have trouble with that.
That would be trouble, yes. I just want to take, I think we have a few more minutes, but there are a couple of questions in the chat. So just as a theme, there's somebody who has vitiligo and celiac, and whenever this person gets exposed to gluten, there is a sort of eczema around the vitiligo. And the question was, is this all T-cell mediated? And then the other question that comes on in a similar is, what's the mechanism for cognitive symptoms? For example, learning issues and so on. So Jason, I don't know if you have any thoughts on that question about what is the mechanism for this person who gets exposed to gluten, who has vitiligo and celiac, and then cognitive symptoms.
I mean, eczema has been associated with celiac in sort of studies, but whether there's actually a mechanistic link, I'm not aware of that. But I think it would be important to exclude dermatitis herpetiformis, which is a itchy blistering rash that may be masquerading as eczema in this situation, because that is definitely driven by gluten and linked to celiac disease. And we don't really fully understand the immune pathogenesis of dermatitis herpetiformis, but there may be immune complexes in the skin at the dermo-epidermal junction. We know that there's a lot of neutrophils in that area, and that there's probably an antibody as well, that transglutaminase type antibodies, isotypes that are present there. I would encourage that person to speak to their doctor and maybe even get, perhaps a skin biopsy to see if this could be dermatitis herpetiformis.
Thank you. Knut, anything to, there's a comment in the chat about discussion you had in the previous session about the neurological and the MRI changes with celiac changes. And so I guess that tying in with the cognitive symptoms, any comments?
Yeah, I think they do. I think there is a reason to be maybe concerned about the brain health of in celiac disease. I mean, if you do careful MRI scanning, you do find quite a lot of differences, not gross pathology, but you can find if you do it carefully. I think that this is well described from UK studies done by Sanders group and colleagues. Mechanism is not at all understood, but you could imagine that this relates to the cognitive dysfunction, which we know is present. I mean, that's for sure. But the mechanism of cognitive dysfunction is not well understood. Cytokines could be involved. Other factors, microbiome related factors, etc. So I don't think we can address it properly.
So in that regard, we had last time a symposium, and I just want to tell everybody that we do have an ongoing brain fog study at the University of Chicago, one end for children, but also in adults with just a one-time challenge study. And we now have IRB approval to receive patients from all the country coming with the ability to stay 2 nights at a hotel at the University of Chicago, and where we are analyzing psychological cognitive test, MRI, cytokine release, but also serotonin release, histamine release, and other components to really try to establish the mechanism. So if people are interested, they should go to our website.
So the difference between that study and the pediatrics is we don't do the gluten challenge. As Marisa said, we'd never go past the IRB. So we're looking at the kids who have just been diagnosed with celiac disease, biopsy proven, positive serology, who have neurological symptoms, psychological neurological symptoms. And we are doing the same with the functional MRI, EEG, and also looking at the neuropsych eval, and then going to follow them once they start the gluten-free diet, which would be their treatment at this time. So hopefully we'll have more to report out in maybe a year or two. So one more question, and I'm sure I'll be told soon that the time is up, but there's a question in here, and maybe Marisa will start with this with you. So it's a neonatologist who has 2 children who have learning issues, whose wife had undiagnosed celiac disease during pregnancy. What is the effect of undiagnosed celiac disease maternal on fetal development? And I'm sure that that's putting you on the spot a little bit, but everyone else obviously will help in as well.
No, I'm so glad that you asked that question, because I was just about to type a response to it. So, I think we don't have a full picture, at least that I'm aware of, in terms of how maternal celiac disease impacts the fetus. There are some birth cohort studies that look at outcomes like low birth weight and have found associations. But I think, quite honestly, thinking about the prospective birth cohort studies that I'm involved with, Daisy and Teddy, we didn't really take a deep dive into the pregnancy and the mom. And I think people have realized that that is a very important potential association. So I think more to come on that, but I don't think there's a lot of really great data right now to speak to that question.
Anything that you would like to add?
No, I don't work with that. Well, I maybe I should say we have been discussing a lot today about all the concerns for the celiacs, but what I really find these days is that almost all celiacs they are bothered by abdominal problems, fatigue, but rarely biochemical alterations. I rarely see iron deficiency, I rarely see folic acid disturbances. And my interpretation is that I think we pick up celiac disease much more early now than what we used to be, than what we used to do. So I think early diagnosis is really helping the celiacs not being really flat on the iron when they come to diagnosis.
Thank you. And Jason?
I'd have to say that I think for my pregnant celiac patients, I do think it's an important time to try to ensure the disease is really under control with strict gluten-free diet. There is a little bit of evidence for transglutaminase being anti-angiogenic and potentially impacting placental and trophoblast formation. So that has been postulated as a possible mechanism, which underscores, I think, the importance of trying to get celiac disease under control, because I think most of the population studies that Dr. Starr was referring to, really show those potential complications in women who have active disease as opposed to those with treated celiac disease. So again, it underscores the importance of ongoing medical follow-up and ensuring the disease is treated as best as possible.
Thank you. Bana?
Yeah, I think this was a great discussion. So Thank you very much. And I think that it just shows you that there will be more studies, and I think some important changes that will be upcoming in the few years to come.